Hello, welcome to the Viewpoint. I am Mohamed Mbouch. The Gambia has so far confirmed 17 cases of coronavirus infections, 1 death and 9 recoveries. In neighboring Senegal, they've confirmed 1,329 cases, 11 deaths and about 470 recoveries. When we look around Africa as well, by now we've recorded more than 42,000 confirmed cases, and by the last figures that I saw, and we should be careful here because numbers are constantly shifting, it's an evolving reality, 1,759 have so far died, and more than 14,000 have recovered, and all around the world there are 3.5 million reported infected cases, and more than 250,000 have died from it. So far in this country, we've been among the countries with the lowest, in Africa at least, among the countries in Africa with the lowest numbers of confirmed cases. But why is that so? Is it reflective of how successful our containment efforts have been? Should we expect a spike in the numbers as we've been seeing in other countries as well? Well, here to help me answer that and other questions is Mr. Modunjai. He is the Director of Health Promotions and Education at the Ministry of Health. He's also the Chair of the Risk Communications Unit of our battle against it. He will tell us more about himself. Welcome to the Viewpoint, Mr. Modunjai.
Oh, thank you very much, Mr. Mbouch, and thank you for inviting me to come to Viewpoint. I'm one of the fans of the Viewpoint program. I've been watching your programs, and then I never expected that I would sit face to face with you. And today is the day that I've come here to sit with you and discuss with you. And as you rightly mentioned, I'm the Director of Health Promotion and Education at the Ministry of Health. And also in this current pandemic, I'm also the chairperson of the National Risk Communication and Community Engagement Subcommittee of the National Health Emergency Committee on COVID-19. And basically, our role is to ensure that we create awareness, we engage communities, we look at materials that are to do with awareness creation. Materials could be either electronic materials like audios and videos, and we also look at messages. And because, as you know, risk communication, it's really dynamic. And at a point in time, as the situation is also changing, you also alongside change with the situation. And that is why we are also constantly reviewing our messages to see, like currently what we are now talking about is the issue of denial, and then also the issue of stigma and discrimination. And that's also so these are some, as we are moving, we started from prevention, like what the disease is all about, how can somebody prevent themselves, and now we are moving to another level. So
absolutely, we will get to all of that in due course. You see, I was a bit confused, in the past weeks when I was reading in the papers. You have a Director of Health Promotions, and I also do see an acting Director of Public Health. Okay. How do you demarcate the responsibilities? How is it done?
Basically, health promotion is in real terms is called the new public health. Public health is the bigger umbrella, and then that was the colonial time when public health used to be very powerful, and then it's the act of prevention, and then also promoting and as well as prolonging life. So it also involves a lot of issues into that. And then looking at, for example, the Public Health Act of 1848. I know if you can also be able to remember Sir Edwin Chadwick in 1800 to 1890. He's the father of public health. All the idea of public health came from him. And his focus was on the issue of how do we improve sanitary conditions of the laboring population of Great Britain. And as a result of that, in 1848, he was able to come, because of that report he wrote in the living condition or the sanitary condition of the laboring population of Great Britain. That was why the issue of the Public Health Act came up. He was the one who first convinced the government of Great Britain to come up with a law to protect the laboring population. This laboring population, in those days, people were living in sewers. And then like sewers, I mean, talk about, sewage, and I mean, it's all the where water, people have to stay, and we allow water to pass, and they have to be at the corner of the sewer. And then because of that report, that has brought in advancement in public health, and that is why we call him the father of public health.
Absolutely.
And then
so let's just
when it comes to health promotion
the
now,
new one, absolutely, the difference between the old one and the new one. Yes.
Is health promotion is all about we call it is defined as the process of enabling people to gain increased control over the determinants of health. And you talk about the determinants of health, there are many of them. You have the social determinants of health, you have the environmental determinants of health, you have the biological determinants of health, and all those issues, health promotion also cross that. So it's more or less, also cross across all sectors. And then in health promotion, we're also making the healthy choices the easiest choice for people. Like if I ask you, Mr. Boyd now, do not eat meat, but I should also be able to tell you an option, and that option should be something that you can also be able to afford. So you can see like health promotion is talk about using the whole of government and the whole of society approaches. Yes. If you are in health promotion, you only work across sectors, and you even work outside the health sector.
That's it. So I take it that your decisions are multi-sectoral.
Exactly. Multi-sectoral and also involving all stakeholders, and either government level or at societal level. And the society level, that is why if we look at our committee, the risk communication and community engagement subcommittee, it's really diverse, multi-sectoral in nature, and I think we brought in people from specialized areas, either in the area of communication, in the area of water and sanitation, in the area of other areas. So we put those people together, and in the area of focusing on communication and engaging communities. Why we are engaging? Because the backbone of health promotion is about intersectoral collaboration, community participation, community engagement. You are also asking for community action. So when we do the community engagement, we allow them now to develop action plans. And in the development of action plan, they have to take the central role in it. They must be at the center of the focus. So therefore, if they put them on the center of focus, automatically they will decide on their own, they come with their own plan, and then they will implement, and you are there to guide them, you coach them.
So they take ownership
of the program.
So I'll ask you this. The question I asked earlier in my intro, I will ask you directly. We've got low numbers. Yeah. And when I read analysts around, be it Gambia or around the world, they're quite baffled by it, really. So I'll ask you this. Is it reflective of how successful our containment efforts have been? Or what do you attribute it to?
I think basically we were able to put up a plan. And before the plan, first I must have to thank the Honorable Minister of Health, Honorable Hamid Lamin Samate. When we had the first report of the epidemic at that time, before it turns to be a pandemic, automatically reports have been circulated all over that there was a case of COVID-19 in China. That was around December. So what he did was he was able to put up a technical team. And this technical team, we were able to come up with a press release that came around the first week of January to inform the public that there is an outbreak of coronavirus in China, and then yes, it has not come to the Gambia yet, but we are giving an alert to the public for them to be aware, and that is where we started our intervention. So his first meeting he called was like, let's sit together and see and strategize as to what can we do. And then because we had to brainstorm as technical people, we had to brainstorm together. And then first he said, okay, why can't we now think of assessing our points of entry? Because when you talk about disease like such nature, you think of like who comes from where and how do they come to certain countries. So looking at the travel history, for example, when somebody comes from a border, you have to ask the travel history. So as a result of that, he was able to advise us to come up with identify strategy to assess the points of entry. And we know, as you know, we have 9 official points of entry in the Gambia across, including the ports, the airport and the seaport. And then those areas where we look at the staff capacity. What do they have, for example, in Jibor? What do they have in Nyamanari? What do they have in Amdalai, as well as Farfanye and other points of entry? And then we assessed the capacity of staff, the existing capacity, what was there. And then the minister himself, what he did was like, he said, okay, I want to see what is happening at the airport. And we thought, okay, that Sunday, it will be difficult for us to get flights. And then because we have been told that people are coming from other countries through flights, so that is why we were able to visit the place. And it was on a Sunday. We went there, he was able to witness about three flights. One was SM Brussels, one was Sky, and the other one was Air Senegal. And then when people came in, and then as they come in, he was also observing. I said, okay, how they should come in. And initially, what was happening at the airport, all the
all the time, the WHO has been warning.
Yes, they gave a warning. Yeah, WHO gave a warning to countries that we should also be able
emergency.
to. Yeah, it was declared as an emergency.
Should we have stopped the flights then?
No, at that point in time, what we did was, how do we strengthen the points of entry? And specifically was the airport. So, and then as you know, I was just trying to explain, like when people come at that time, they will just go, passengers will just go straight to immigration, and then leave and then go to health. So as a result of the visit of the Honorable
Minister... that was a failure?
Yeah, no, that was what was happening before.
But this was at the time when the WHO...
No.
When was this?
This was just like, I would just say, for example, originally, I mean, what we have been doing, or what has been happening at the airport is that when people disembark from the flight, they go straight to immigration, get clearance, and then go to health. And then, as a result of our visit, when we were able...
So when was the visit?
That was around, I think, the second week of January.
Second week of January?
January, yes. Then we got an alert of this emergency, this public health emergency. It was declared as a public health emergency. And then we said, okay, let's try to strengthen our points of entries. That was why the first visit was at the airport, to see the functionalities of the thermographic thermometers, the cameras. And then we also look at the computers that are also there. We also look at the staff who are also working there. Are they working on shift? All those things were assessed during the visit of the Honorable Minister and the team.
How many thermometers were there at that time?
At that time, we had the handheld one. We also had the computerized one.
How many?
And then there were one at that one, yeah, at that time. And then, but because what happens is like...
What would be the appropriate number to have, for instance?
No, it depends on the capacity of the airport. Like, for example, the office that will have been allocated to health can only accommodate only one camera, because the camera has a screen. At that television screen, as people come in and pass the camera, it will just take their images, and the images will be seen on the camera. So at that point, we had complaints from people that there were no health workers at the airport. But what was happening, when somebody is in that cubicle, it will be difficult for you who is passing by to see that individual, but that individual inside the cubicle can see you. That was what was happening. And people started blaming the health sector, that they are not doing A, B, and C, they are not doing their job. But when we went there, that was what was clear to people, that because of the cubicle, it is also tinted. And that's the design of the cubicle. And then as they come in now, they take the minister himself was there. I think you must have seen that on our Facebook page, when the minister was himself there testing the computer and also the thermometer. So that was something that, and we also had a handheld one with the officers there on the ground. So what we did was we said, okay, he said to us there, why can't we now change the strategy? Instead of now passengers starting with immigration, why can't they start with health, so that when they disembark, then they will be temperatures will be taken outside before they get into the hall, because in the airport it was going under renovation. So as they come in, their temperatures will be taken, and then also they will also be sanitized. They will be given sanitizer to rub, and that was also done in our presence on that day in the flights.
Absolutely,
that was good.
One absolutely appreciates the efforts being done, but in the end, by 17th of March, somebody had come through the airport, and there were gaps.
Exactly.
What did you learn from that?
What happened is like that was an eye opener for us. We were able to, because
where was the lapse? What happened?
Actually, I would not say there were lapses at that point in time, because what happened is like the person traveling at that point in time did not show any signs and symptoms of COVID-19 similar to WHO classification for COVID-19.
But that's what we should expect,
that could not be detected.
Sometimes you can be asymptomatic.
No, that's true, but that could not be detected at that point in time. That was the problem.
So wasn't
because of that, it could not be detected at that point in time. The person just came, But the person is also a very conscious individual. Went home, I mean, after one day, and then felt that she is not all right. She drove herself to MRC.
Absolutely. So some people are saying that the mechanism we had in place was flawed. If we had automatically said that anybody coming in, you must go for 2 weeks quarantine, automatic, that could have been interesting.
No, in fact,
but we were taking certain risks.
No, actually, we were not taking risks. You know, as a country, at that point in time, we had to wait for WHO guidelines, WHO recommendation,
and WHO suggestion. Why all the time? I mean, we could have taken, we understand the general, the broad arguments, and then it must be tailor-made to what we are. We could have taken initiative, given what we know of the science.
Mr. Boj, I know that you are quite aware of the fact that Gambia is a signatory to the WHO protocols. And then WHO is the UN Specialized Technical Agency for Health. We talk about Technical Agency for Health. Automatically, they deal with technical guidelines, protocols, and suggestions for countries. And that was why we had to wait for WHO suggestions. And then when there were discussions ongoing, and we came up with an advice, not that the Minister of Health can only advise government. And as a result of that, the Minister of Health also advised government to think of now, how do we ensure that people who are flying from hotspots countries, at that point in time was countries that were affected. And the list of countries were listed to say, if you come from country X, we are not saying don't come, but if you come, you're going to be quarantined for 2 weeks.
That's it, but when did that come in?
No.
Because flights had been coming in the whole time.
No, that happened, yes, but I'm saying
and we've already identified that there must have been gaps.
But I know we had some gaps at that point in time. So but what happened is, like, for example, we could have strengthened to say at that point in time, no flight will come. But also, we have to be guided by the advice from WHO.
Well, Mr. Njai, I've seen around the world people interpreting in their own way WHO guidelines. When it comes to social distancing, we've heard about what Sweden was trying to do.
Yes.
I mean, you look around the world, you can see slightly nuanced responses.
WHO come with generic documents.
Yes.
And when you talk about generic documents, when it is given to countries, now country will now adapt it to their own country situation.
Yes.
But they come with generic documents. And most of the time, these generic documents, they work. Sometimes certain countries don't even change the generic documents. Sometimes other countries change because of the way the countries are, and they feel that they need to adapt it to their own country situation. But as a result of that, we had to improve from where we said, okay, we said, there was a declaration that any flight that comes into the country at that point in time, will be quarantined. Anybody who comes from a hotspot area will be quarantined for 2 weeks. But that was a challenge. You remember when the first flight came? People were supposed to be quarantined, and they said no. And you heard about the story, that people were supposed to be taken to Golden Beach.
Was that a failure of security?
That was
because when it comes to quarantine somebody, sometimes the person may not want to go because of the public health imperatives. Some element of coercion is in quarantine, really.
No, what happened is, like, most of the people who were on that flight, they knew that when they come to the Gambia, because the airlines have communicated that when you come to the Gambia, you will quarantine. But they were taking it for granted that, okay, we are going, don't worry, Gambia, we can easily find our way. Some were even tried to sneak, but they were being caught. But what happened is, like, anybody going to a new environment and you don't know where you are going to be taken, you can sometimes they resist. But they didn't know where they were going.
But this is where we needed our authorities to be tough. Because you've got the facts. And you are seeing, you've got data information that other people didn't have. So you had to be tough.
No, we were tough. I wish we were there. Our public health acting director and team were so much active on the ground. The permanent secretary was there, and then the acting director of health service was also there. But what happened is, people were saying Minister of Health was not represented at the airport at that time. You can see how people can make allegations on authorities. Because they were saying, so that when they make that noise, people who can say, oh, how can you bring people from other countries and you keep them here? None of the authorities of the Minister of Health did not come and see them. And people can make a case out of that. That was what they were suggesting. But
so you mean the authorities were
there?
At the
The
airport?
permanent secretary was at the airport. You know what? We were having a meeting, and the permanent secretary instructed that, and together with the minister, at that meeting, that there should be water and food for people who are coming.
So the permanent secretary was there?
Was at the airport.
But then don't you think really, situations like that, you really possibly need health workers and you need the security. Perhaps those people would have been more significant to the situation than the permanent secretary.
We had securities, but we were not expecting that people will resist. You know what I mean? Like, we all know, we thought it's going to be a normal situation. But it turned to be like, we are not going. So it seems we had to call for enforcement. So security, that was what happened exactly. So, but what happened is, like, after, with all the noise, okay, they were transported, to the quarantine center. Somewhere, oh, no, I'm not coming. And then they had to break the door, and then some have to escape.
14 escaped, but this is what I mean.
Yeah, no,
but that was a botched job. That was a botched job, really. And
that was a
failure.
That was a failure. No, it's not a failure, but it's a weakness on our side.
They escaped.
They escaped. What happened is, like, but they were even there because our staff at that time were not armed and they don't have anything to protect themselves. And then they had to threaten them, and then whatever they just opened the gate.
Do you need to be armed? Just management, crowd management.
No, crowd management.
That sort of thing. You don't have to be armed.
But like this, the band. I mean, like having this police that they have these protective gears and so on. Like in case somebody start throwing stones, and that's what some of them were doing.
So there was something wrong with the planning.
Exactly. No, the planning was not. Mr. Boat, I would not accept
because when you're planning,
what happened is, like,
you consider different scenarios. Prepare for the worst, hope for the best. That sort of thing in planning.
What happened is, like, it could be, we could, but as I said, Gambians are known of being very peaceful. That is what we.
But that's just a platitude. I mean, human beings are far more complex than that.
Gambians
we tend to say that, but that's just a stereotype. I mean.
Yeah, but the Gambians are known for being very peaceful, and that's why we were not expecting any violence. But when they went to the hotel.
Then you've not been listening to the TRRC, Gambians and peacefulness. We did so, but I mean, we can be all sorts of things.
Actually, in this case, because we thought their health matters to them, and when we tell them that you are going to be quarantined, they will appreciate it. That is what we thought. And if I'm coming from an affected zone during a public health emergency, and I've been told that I'm going to be quarantined, I will really appreciate it. Because now they are now trying to help me to protect myself and my family and the people I'm going to get in contact with. And that is exactly what we thought. But okay,
so now have we improved the system? Now what is going on now? What we learned from that experience?
As we are moving along, we had what we call the Logistic and Safety Committee, Logistic and Security Committee, this subcommittee, headed by the Director of National Pharmaceutical Services. And then there are members of the security force, the military, the Joint Operations Center. They are also represented in that committee. When we knew that there were security challenges at the beginning of one of our first quarantine center, that was at Golden Beach, we had to reinforce the security at Golden Beach, at Badala Park, at as well as Swan Beach and other places. I think that was, and Bamboo. So that's what we did. And definitely the securities have done very well. And then there was no violence. And then they were just there to ensure that people are well protected. And then few people started complaining about our accommodation. But because they don't want to stay there, they can make all sorts of allegations. But imagine you take somebody to a quarantine center, you give the person, good accommodation, with air conditioning, with water, daily meals, with security, as well as psychosocial support and medical support in case they have other medical conditions. Some with diabetes, for example. Some are asthmatic. Some are other with other conditions. Doctors are there 24 hours round the clock and nurses to help them. In those days, in 1345, you remember the plague, the bubonic plague.
The bubonic plague.
You heard about it.
That's where quarantine, the word quarantine came from Venice.
Exactly.
What
happened is,
how
were those people treated?
Yes, but I will put in this criticism.
Now, I'll wait for you.
We've heard this criticism, really, particularly from the National Assembly member for Banjul South. Remember, this was in the context of the quarantines. She made the allegation that where her mother was quarantined, there were others I've heard Lebanese and others who were coming to take their people from there. That was why, which emboldened her to say as well, I am going to do this. So there's a lot of criticism about what was actually going on, in spite of the wonderful rosy portraits here you're trying to give me. That everybody's
actually,
did you confront? Did you investigate that? Was that investigated?
I'm not very sure. In fact, that information you are just giving me now, that Lebanese were going there to take the family. That's the first time I'm hearing that.
It was all over in the papers.
But what also
she justified herself why she tried to do that. That was what she said.
According to what we got,
a National Assembly member, you should have investigated it. Did you investigate it to see whether it happened?
I don't think that matter, I'm aware of that matter to that extent. But if that is the case, we'll investigate. I'm sure the investigation was going on if that was, because at least if our staff are being accused of something, we will investigate. I'm very sure of that. But I am not aware of that situation. But I know, I'm also aware of her actions. No matter what has happened, but the actions that have been taken, that was what I'm aware of, that one. But I think, for me, I see it as misunderstanding, miscommunication. Hadn't been, there was that, they listened to each other, I don't think that would have been any problem. But those things are things that we all have to learn from, and herself have to learn from. And then the people who are, having that issues with her also have to learn from. But I think, as I said,
granted, on a broader point, even regarding that, it's still in the context of what we were talking about. On a broader point, we've often said, complained, bemoaned, lamented. I mean, the words out there about the fact that we can have wonderful regulations. We write them even in Shakespearean English. Yet, when it comes to implementation, earlier we were talking about the entry points, the official ones, but there are also so many irregular ones. Our reporter went round to some of these entry points, and the situation that he had found there, they were all really awful, quite awful. And recently we've been told that there were 25 people that quarantined. They came through from Senegal when supposedly, the borders are supposed to be closed. So when you look at these facts, there are many gaps, really, within our defense.
I think this is a novel coronavirus is new. Novel is new. And it's also helping us to learn more and more about the disease. That is what we have been doing. What you said, we have 9 official points of entry. The rest are unofficial. People can come in and out. You remember certain communities in this country, you have the whole building in Gambia and the fence at the gate is in Senegal. You've seen that. I don't know whether you've seen that, but I've seen that in other communities.
Yeah, we realize that. I mean, obviously, given the geography,
and then, I'm so if you are living in those borderland communities, because you are very generous somebody, very kind somebody, you would like to sometimes give them a chance to come in. So you're such type of people are the one causing trouble for us. You want to be very kind to people, to visitors, and you want to wait until, you're asking them to wait until it is late and you want to sneak them into God. That's what some people are doing.
Absolutely.
And these are, some of them are opinion leaders. Then
is there a deficit of information? Because if people understand the public health risk they're taking, for themselves.
No. In this country, when we started our campaign to raise awareness, I think we can always say that we did it for Ebola, and definitely WHO really assessed our risk communication and community engagement as satisfactory, highly satisfactory. Because what they did was they came down, the consultants came one night in Gambia. The next minute they were all the communities in the Gambia asking about Ebola, the signs and symptoms, everything, and people were able to tell them. Likewise, also COVID-19, we used the same strategy. We didn't want to reinvent the wheel. We said, let's now move on and see what we have achieved so far, and we can also be able to make a replica of that.
But this time people were allowing them in.
No, I'm coming. I'm coming. So when we did what we said, okay, let's engage the village development committees. Let's also engage the alcalos and the chiefs. We call it in general district authorities. And then when you engage them, you are now giving them more information. We did that alongside with the radio programs, alongside with the youth. The National Youth Council is also intervening with the youth. The Gambia Red Cross Society is also intervening, doing the house-to-house sensitization. So people are really aware. But
how effective? How much did it change attitudes?
That is where
that is the key.
You and I know.
That is the key.
Behavior, changing attitude cannot take overnight. Cannot be done overnight. You keep on talking, people keep on doing other things. But you keep on encouraging them, and also you know that there are different stages of learning. And that stages, somebody can be the largest, for example. But when they come, they can even be the best. But they keep on moving. So people are learning about the disease. But the problem here we have is the issue of denial. They are, no, this is not this is not true, and you know, I know, don't talk about it.
But
that's
truly,
what many people think.
True, but truly, Mr. Njai, here it's your challenge.
The denial, no, I'll come back. That's
you
our
know what I
challenge.
mean?
I'll
This
come
is
back to
really,
the challenge.
it's a challenge for policymakers, because we all know that really.
Do you mind if I complete that particular component?
Okay, all right, please do.
Basically, like, if you look at our engagement, IOM, International Organization for Migration, was able to help us to build the capacities of staff at the point of entry. And at the point of entry also, we have this UNDP-supported buildings, which have isolation holding centers, and as well as offices for the public health officers, which are also used by other departments at the borders. We also did a training for engagement of communities on the borderline communities. So each of the borderline communities, from URR down, they've been engaged as to what they should be doing, what their roles and responsibilities are.
But this is the thing.
And also,
but how effective?
No, it's
the
effective.
effectiveness of it that we're talking about.
There was 3 or 4 days ago, or 5 days ago, 10 people were being taken to quarantine. You heard about that?
Yes.
Why? Because the people who are engaged are aware and they know about it. They had to call the 1025.
But this is the one we knew about. This is the one we knew about. Possibly there were others that had gone through that we didn't know.
I'm coming.
So it depends.
Now that we are trying to reinforce our interventions, we now said the securities now will have to conduct border patrols, which was not part of the intervention, but now the securities are now doing daily and regular patrols.
Without any equipment. One of our reporters went with them and came back with a report. They don't have facilities, much facilities.
No.
I mean, in fact, in one of the posts, apparently, they used an old shop, converted into a kind of office.
That is
for
not a
the
recognized
police.
point of entry.
So you have all these irregular...
No, the recognized point of entry we have. These
They're
are all
fine.
well built. Your people have seen it. The one in Jiboro, Istanbul, you can even go there and you can have it as a very nice office.
Our reporters have been going around.
Oh yeah, but they know about that. They know about that. But the ones they have
on.
seen, I'm sure they must have been talking about,
the
for example,
entries,
Dimbaya, for example.
Yes.
Dimbaya, maybe Daselami, and then maybe, those are the areas that we can, and perhaps Kartong. These are not official points of entry for the purpose of disease prevention or for the purpose of public health. That is not, because, like, for example, if you have to have a point of entry, official one, you must have immigration and all other security apparatus within that particular office, and also have health authorities there with the office and all the other materials. You're talking about equipment. The ministry have equipment in our central medical stores, but we have a system of distribution. If you know that you need equipment, the only thing you need to do is to make a request. Because when even the donation we are having, it goes to the logistic management information system.
So when we say
from
equipment
level,
here, what we say equipment, what
like
do we mean?
They will say
for
PPEs.
Instance, what?
Some will tell you, we are here in this point of entry, we don't have PPEs. They have PPEs. They have PPEs, but you only use those PPEs when you are about to start operation. Like, for example, you suspect somebody, or somebody comes in and is highly or is sick, but doesn't have the disease, but is also sick. That one can be a suspect for you, and you, before you call for the ambulance, you need to make sure that you manage this particular person, put the person, he or she, at the holding center. That's why we have a holding center within the point of entry. In this holding center, then you can now call the ambulance to come and pick them. Then you also tell them the condition of that particular individual. If it is a highly suspect, for example, for COVID-19, then they will also be prepared to come and with their gears and then fully prepared with PPEs to come and then collect this particular individual.
Do we have, do we have sufficient PPEs?
I'm sure all the regions have been supplied. And
how many?
I will not be, those I would say in thousands.
We've got thousands.
Yeah, we got PPEs.
Our health workers.
But the PPEs are meant for a purpose.
Yes.
You only use PPEs If, for example, you have to collect samples, for example, or you are managing a case, or you are in a place where you deal with somebody who you feel is a suspect, you want to carry, or you want to help the person to be kept in a holding center before the person is taken for to the next level of care. It could either be the treatment center or the quarantine center. So those, but not that every time you have to be on the PPEs. No.
Obviously,
No.
I mean, and earlier on you talked about staff capacity, training them. How many staff were trained?
I will not be able to tell you the exact number, but in each of the points of entry, at this point in time, you have about 2 to 3 staff. Sometimes, like Farafenya, have about 4 staff. That's I mean.
So this would be the official the 9 points.
The 9 points. So at the airport, it used to be like 2, 3. At some point, we made 11. So they work on shift. And now the airport is closed now. Some of those staff now have been added to the contact tracing and as well as the rapid response teams.
I wonder, because when I read about these things, it's quite fascinating. Around the world, they've got this thing they call modeling. You model your situation to see how worse things can be, what you can do, because it helps in the response planning. Have we done any modeling for us really to have a more coordinated, well-concerted and directed
I'm coming to that.
Response?
Actually, if you talk about public health emergency, you talk about 2 things. One is preparedness and the other one is response. When we were at the level of preparedness, we were doing assessment of the points of entry, assessment of our facilities, the treatment centers, the isolation centers, and also the quarantine centers. When we did assessment and they are fit for the purpose, then we make recommendations and suggestions. We identify them. Then you come to the next level. If there is a case, for example, then you now go into response efforts. And in the response, we also make sure that there are regular coordination meetings. Regular coordination meetings are held every day from 9 a.m. to 10 a.m. every day. And then every Monday also there are strategic coordination meetings, which are also held, and then they also comprise of various subcommittee leads. And also some technical experts in that committee. And we brainstorm, comprise of UN agencies. In that meeting, we discuss, we make presentations on a daily basis. Each and every subcommittee, whatever you are doing, you make a presentation. And now we are not meeting physically, but we are also doing that on Zoom. And you make a presentation, and people will make comment on that presentation, and you adjust. If you also have challenges, you raise it, and then it will be solved at that point in time. And most of our issues are solved in those meetings.
When you take a decision, whose job is it to make sure that, to monitor, to make sure the decisions are implemented? Because this is really where the issue is, the crux of the matter. Okay. Whose job is it to make sure that these decisions are implemented? Who monitors?
Okay. We have the monitoring is done purely at the level of the central level. The permanent secretary, the honorable minister coordinates and monitor the implementation of activities to ensure that each and every subcommittee lead must be able to deliver. You must deliver, you must provide results, and you must also be able to report. And then we also have another committee that is also monitoring the Minister of Health. That is the special committee on the state of public emergency was set up by the National Assembly, and that we also have to go back and make presentations. Likewise, in addition to that, we also have the Select Committee on Health also. So we also make regular updates. And also, in addition to that, also we have these regular updates also on a daily basis. We give an update as to where we are. And this update also covers a whole of areas from the coordination level, and then we also have the logistics and security subcommittee, risk communication and community engagement, laboratory and surveillance, psychosocial support and research, and as well as case management. So these subcommittees have been implementing their activities, and they also make an update. And then anytime we have been asked by the National Assembly or the Special Select Committee on the implementation to ensure that the state of emergency regulations are implemented, and then we also make presentation to that particular committee. So this is really that's the way it is happening, and we all report. We provide our reports to the Honorable Minister who also have there is also a ministerial committee I don't know whether you heard about that.
Yes.
And that the ministerial committee is also
Are you referring to the cabinet? Is it the same one?
The cabinet select committee on COVID-19.
Yes.
And it's also chaired by Her Excellency
the VP
Vice
President. Yes.
So you can see what is happening right now. So now we are scaling up. As we are scaling up, and also the President, His Excellency the President, also oversees all the entire functions of COVID-19. So you can see how things are from the President to the Vice President to the Minister, and then to the various subcommittees, and as well as now at regional level.
No, but here I'll have to say,
I'll come to the regional level. At the regional level, we also have regional COVID-19 coordination team, and also they are normally chaired by the regional governors. And then at district level also, and that COVID-19 committee, you also have subcommittees. You have surveillance, you also have case management, you also have various subcommittees under that, and risk communication. So you can see the coordination, for me, the flow is excellent. From the top
some people
to the down,
but this
and
is
even now you can even get from down to top.
Absolutely,
Yeah,
absolutely understood. But again,
and that is why we can say that is why we are making progress.
We'll come to that next.
Yeah.
But this is what some critics say. I mean, most of these things are quite process-based. Process-based kind of administration, fine, all well and good. But what about outcome-based? What are we seeing with the outcomes? Yes, things have been slow, but again, we saw the last time that I think the largest number of spikes was in 5 one day, because previously it was just one, stuff like that. Suddenly we've got 5. Some people are saying that you are not testing enough. That is the reason, one of the reasons why we haven't got high numbers. As I've got here, total tests so far from the last numbers I saw, about 566 since.
Yep.
That's been the total tests so far. And then who are the ones, and then in contact tracing, they said 720, stuff like that. So the testing, that's quite low.
I think I have to
go
back to you with regards to the issue of testing. We as a ministry and in collaboration with other partners, we knew that there is a need for people to be tested. But as you know, there are challenges. When we reported the 5 cases, that was an eye-opener for many people, because those are the people who were on quarantine. You remember now people were saying people should not be quarantined. But I wanted to take you back to the 1345, 1348 bubonic plague, and you know what I'm going to talk about. I think you know that already.
Why did you come to the Spanish flu?
Because why I'm saying this,
1918, that's too far back.
No, okay. The Spanish flu. Because why I'm saying this,
all right.
How people were quarantined. Some certain prisons were closed and used as quarantine centers. But we are not doing that as a country. In other countries, some people were supposed to be quarantined. They were taken to the hotel and they were complaining. That particular country, the president had to order for them to be taken to a primary school. So you can see how things can happen.
So what's the point here?
So now we are giving them comfort. We are giving them all the support, and they're saying no. And as a result of the quarantine, we got the 5 cases.
But that's weak authority. I mean, what do you mean you're saying no? I mean, this is a public health. We've got this, we've declared a state of emergency.
The so-called democracy.
Public health emergency.
So-called
that's what
democracy.
we've declared.
People feel they have their own right. They can say anything, they can do anything. In social media.
But what they feel and what the facts are, they're different.
But the facts...
So it's not about their feelings.
If we are to act at that point in time, they'll come here and report and say, health have acted on us negatively.
Then they would have,
and they start blaming.
Then we would have questioned them.
They had no, but
then they would have justified what they said.
Them.
You have to justify
you
actually
will
what
question
you said.
Them, but not everybody will be like you. I don't know whether you see my point. They will. The moment certain people complain, it's a fact for certain people. But actually, when we actually look at the public health measures, I think we have been a bit flexible with the government people. We have been doing most of the time talking and raising awareness. That is what we feel should be done. But at some point, when we feel we cannot no longer bear, we have to apply the rules. And that was what we're almost, moving towards. And I think now that people are compliant gradually to our rules. And then the issue of testing, we propose that if we, for example, have a case in a location or in a locality, let's start thinking of having mass testing in that particular locality.
For instance, in Bakau.
Now, I want to give you one example. Why we moved to Bakau. I'll give you a scenario. When we moved to, we had case in Safidin.
Please summarize. We're coming towards the end of the program.
We had a case in Safidin and Sumbala. It was difficult for us to do mass testing. There was resistance. And we didn't want to force anybody. It's democracy. That's what you know about that. People feel they have the right to say anything and to do anything. We just say, okay, we don't want to force anybody. We had a case in Bakau, and then we approached Alkali. This Alkali is an excellent someone, 2 of them. And they even went to the extent of, when we went to sensitize them about our plan to do...
Maybe shouldn't you have consulted him first? Shouldn't you have involved everybody in the planning before going there?
We have done that already.
You have done it?
We have done that, because we know that we just went there to tell them...
Did you get the consensus? Did you get the agreement?
We got the consent of the Alkali, the 2 Alkalis in Bakau. I want to give you one example. When we went there, the Alkali, one of them offered to give us a vehicle. And we said, no, we have a vehicle. We have a special, vehicle for, that's the 1025 vehicle. Now it's one of the most famous vehicle in town. And then we told them we were going to, and the team had a very good discussion with them, and they accepted. They even offered that they will themselves will participate and make sure that everybody is aware of this screening. And then when we did the first screening, the first day on Sunday was 366 people were screened. And then as of yesterday was like, yesterday was 231. So, but because the Alkali, the councillors, and the youths, with support from National Youth Council, all of them played a part in the security to ensure that at least people come out in their large numbers. And they came. And then they couldn't even finish it. The next day they have to come and do the testing. And then we thought, Bakau people, we have to thank them. Why we say that? Because they have seen health as their priority, and they have taken action to ensure that screening is done in their community and by inviting the health authorities to come and do the screening. And then we thought it's going to be like, a signal for other communities, and that exactly has happened. Now many people are now asking, when are you coming to our communities to test? And at the beginning people are saying, no. And despite the fact that in social media, people were making noise that there is a need for mass screening. That was what was happening. But when we wanted to approach them, no, we don't want. And there was decision. But now, they themselves are now demanding.
But this is it, you know how people can be because of maybe the stigma attached to it.
Certain people want to sit on the fence.
And stuff like that.
Certain people want to sit on the fence to see whether they will fall on the side of A or B. And when it didn't happen, like for example, there is no damage and there are no issues, now they're saying, oh, no, because, okay, now I'm ready to be tested, because they were sitting on the fence. They couldn't decide. Well, now certain people are now deciding. But we have to thank the community of Bakau for really
for this.
We'll
go back to that. Just one more.
And the same thing is coming in North Bank and CRR, and as well as URR. The team is currently in those areas to now talk to the authorities for us to see the possibility of conducting mass screening in those areas. Absolutely. So as of now, we've screened about 597 people in Bakau.
Okay.
No,
yes.
That was something that was really
absolutely
a good one.
So the other fear that people have is that because the whole country, understandably so, we are so concentrated on defeating COVID-19. What about the other healthcare facilities, vaccinations or immunizations? There are other areas. There's a fear.
I want to make one clear message here. There was an audio and also on social media, news, fake news, I will call it fake news, that the Gambia is going to do, embark on COVID-19 vaccine trial. And that has made most of the people, especially the people of Brikama area, not to attend our RCH services. The services we are providing to women and children, like immunization, screening, and other services that we have been providing, people are not turning up because of that messages.
How widespread is this? You've just mentioned Brikama, but how widespread is this across the country?
What happened in Brikama, the next minute is in Nyamanari.
That's it. So now, what are the dangers, the public health dangers for that?
I want to now make it very clear that the Minister of Health and the government of the Gambia have not made any argument with any individual or institution to embark on COVID-19 vaccine trial in this country. It is a false statement. It is not something that is true. And then I want to urge all the women who have been visiting our clinics, pregnant and lactating, and as well as men, because we want men like you to encourage the women to be going to clinic and then for them to continue having the routine services. They will be given their routine immunization services, and there is no trial that is going on in this country with regards to COVID-19. We are not aware of it, and it's not ministry and the government have not endorsed any agreement with anybody, be it individual or institution, to embark on any trial on vaccine. So we want to assure the women that the Minister of Health is there for them, and then we make sure that we give them quality, affordable health services at all times. So we will give them the right materials they need, the right vaccines they need, and the right medicines that is required. And we want to appeal to them. To let them not run away from our service. We are the same people that have been giving them the same service that are still there, so we want to appeal to them to continue taking our services.
So do we have the right medicines? For instance, ventilators, how many have we got? Because I remember recently reading something in Zimbabwe, a relatively healthy person had the disease, but possibly could have survived if they had ventilators, went to a clinic, no ventilators. How many ventilators do we have? Because the other fear is that if we had maybe the right drugs and the treatment and all of these things, a lot of people might be cured. But without some of these equipment or drugs to help us, deal with the situation, and other tragedy would emerge, preventable deaths would happen because of these lacks. That is the issue.
Mr. Moj, when you come to ventilators, I want to allay your fears on that.
How many do we have?
I will not be able to tell you right now, but I know before we got started support from the Chinese government, we had about already 10 on the ground.
We had 10 ventilators
on the ground before we got the support from.
So where exactly are they distributed?
They are at the treatment center. And as you know,
which treatment center? As in MRC?
The
sanatorium? The sanatorium. So 10 ventilators.
Somebody will not understand. But I know when my grandmother and my mother say venture, they will understand. So that's where our treatment center is. And we are also working, the Deban Clinic is being renovated thanks to tough construction.
But how many did we get from Jack Ma's donation?
Actually, I will not be able to know the exact amount now, but unless I contact the logistic team, that is the National Pharmaceutical Services, then I will be able to tell you the exact amount. But I know when it comes to ventilators in this country, we want to allay your fears on that. We have no issues with that when at this point, because the minister has always been talking about that well before we start registering a case, that there's a need for ventilators, and that is why most of the equipment have been included in our equipment list, to be procured under the support of the $500 million. And I'm sorry you didn't ask about that, but people have been talking about. But I'm happy that the Minister of Finance and the team were able to make a very good clarification on that particular.
But what is the clarification? Because there we were told that we'll have the Minister of Health told us that the Minister of Finance was working on an itemized audit of where everything was spent. Because before what we had was what? Consumables. You've mentioned a few, but we still, I'm not sure, I haven't seen it anyway. Any itemized audits of, for instance, $143 million?
No, it will be difficult. But what has been put aside for equipment? And as you know, the minister is thinking of now, how do we expand our existing facilities to make them operational? Like all district hospitals to operate as district hospitals, all major health centers to operate as major health centers with the required personnel and equipment. And then those ones require, and then 100 million has been put aside for that particular procurement process to make sure that all our hospitals, all our health facilities are strengthened, because we're now thinking of strengthening our health system.
How many health centers and hospitals are prepared now, are battle ready, if one can call it that?
All our major health centers.
So it seems now everything is concentrated, it's just MRC. No. What about, how many of them are battle ready? How many centers do we have?
If you have right now,
yes, how many centers?
The health centers we have, including with our minor and major, and we have, like, for example, district hospital, I can just name them to, like, for example, like you have Soma, you have Basse, you have SL, Kuntauru, and as well as Brikama. And those ones, we have a total of about 6 district hospitals.
Do they all have isolation centers and the beds?
Oh yes. You will be surprised.
So and now we are testing. We're nearly there. Just final question. Final question I have to say.
And then if you look if you look at our major health centers also, and also minor health centers, the staff are there, and then we also be able to provide the necessary isolation centers, and also the general hospitals. Buyam, Farafenye. You also have Bundung. You also have Scanifing, and then the main teaching hospital. All those areas have identified isolation centers in addition to the treatment center that is in sanitary.
Okay, so right now there's a mass testing, so you expect that.
Testing have
No,
we started yet?
now,
Yeah.
essentially, because in Bakau it will
Just
probably
certain spots,
that's
yeah.
it. So we're expecting a spike. I mean, so far that's what
But
we're
also,
saying.
the
So you think
samples
we're
that
ready?
came out as of yesterday.
We will hold you to that. You
about
said that we are
109
ready. We will hold you to that. We've come to the end.
109
I'm really
samples are
sorry.
negative.
We've come. Thank you very
that's
much.
a good news.
That's a good news. At least that's a very good news. Thank you very much, Mr.
Thank you.
Bodunjai,
Thank you.
for joining
Thank
us
you.
today on the Viewpoint.
you.
And thank you very much, viewers. Until next time, I'm Mubudin Butch. Bye-bye.